Welcome to this webinar about the most recent findings of the Learning Disabilities Mortality Review Programme. We call it the LeDeR programme for short. My name is Pauline Heslop and I'm the programme lead based at the University of Bristol. In this webinar, I'll provide a brief update about the LeDeR programme. I'll then focus on the most recent findings from the programme, which were published on May the 21st, 2019, and the recommendations we made. Contact details will be given at the end. So let's start with a reminder of the programme's aims. These are to support improvements in the quality of health and social care service delivery for people with learning disabilities, and to help reduce early deaths and health inequalities for people with learning disabilities. And we do this through supporting local reviews of deaths of people with learning disabilities aged 4 years and over. So, an update about the LeDeR programme. The programme was initially established by the University of Bristol under contract from the Healthcare Quality Improvement Partnership. It is funded by NHS England. The programme is now largely delivered by NHS England, with the University of Bristol retaining responsibility for taking notifications of deaths, providing support for the LeDeR review system and e-learning platform, supporting independent panels of professionals, families and people with learning disabilities to assess reviews of deaths that come within the current priority themes, collating and analysing findings from completed reviews, and communicating the overall findings. NHS England has responsibility for the overall governance of the programme. They support regional coordinators, who in turn ensure that the support is provided when necessary for local steering groups, local area contacts and reviewers. NHS England supports local areas to complete reviews of deaths and assure their quality. And they support the Learning into Action Group, a national group that focuses on translating findings from mortality reviews into improvements to services. So, the key findings from the annual report published in May 2019. The findings relate to the 4,302 people whose deaths were notified to the programme between the 1st of July 2016 and the 31st of December 2018. Where accurate information wasn't available at the time the death was notified, we only consider the 962 deaths that were reviewed in 2018, but the baseline numbers are included in each slide for clarity. So let's start with the people whose deaths were notified to the programme. Males account of the deaths notified, females 42%. In relation to the person's ethnicity, the majority, at 90%, were of white British background, and 10% were from Black, Asian and minority ethnic groups. This did, however, vary by age. Of the deaths of children aged 4 to 17 years, 42% were from Black, Asian and minority ethnic groups. Of 18 to 24-year-olds, the proportion was 26%, and of adults aged 25 years and over, it was 7%. In relation to the level of a person's learning disabilities, 27% were known to have had mild learning disabilities, 34% moderate learning disabilities, 27% severe learning disabilities, and 12% profound or multiple learning disabilities. Let's look at the deaths of people with learning disabilities. 62% of the people with learning disabilities died in hospital. The corresponding proportion for people in the general population is 46%. Looking only at the deaths reported in 2018, for which we have accurate information, and that's a total of 962 deaths, a smaller proportion of deaths of people with learning disabilities was reported to a coroner at 31% than in the general population at 43%. Of those deaths reported to a coroner, people with learning disabilities were more likely to have a post-mortem or an inquest than people in the general population. Of 897 deaths reviewed in 2018 for whom the data was available about do not attempt cardiopulmonary resuscitation orders, 69% had such an order. Reviewers felt that the majority of these, so 79%, were appropriate, correctly completed and followed. There were no instances reported of cardiopulmonary resuscitation inappropriately being denied, but there were some reports of it being attempted, although a decision not to attempt cardiopulmonary resuscitation had previously been documented. Of most concern was that 19 reviews reported that the term learning disabilities or Down syndrome had erroneously been given as the rationale for the do not attempt cardiopulmonary resuscitation order. Information about medication was available for 550 adults aged 18 and over whose deaths were reviewed in 2018. 19% were usually prescribed antipsychotic medication, and most of those, 73%, who were taking antipsychotic medications were only taking one type as recommended by NICE guidelines. However, 27% were taking more than one type, including 20 people taking 2 different types, 6 people taking 3 types, and one person taking 4 different types of antipsychotic medication. When considering the age at death, there are a couple of things to bear in mind. First, the LeDeR programme only includes reviews of deaths from the age of 4 years. Before that age, it can sometimes be difficult to identify that a child has learning disabilities. Secondly, we can only report on the age at death of people with learning disabilities who died from the 1st of April 2017 onwards. Prior to that date, the LeDeR programme only reviewed the deaths of people aged 74 years or less. The upper age limit was then removed to align the LeDeR programme with the National Learning from Deaths framework. So the age range of deaths notified was from 4 years to the oldest person who died at age 98 years. The median age at death was 59 years. For males it was 60 years, for females it was 59. In the general population of England from 2015 to 17, the median age at death for people of all ages, including 0 to 4 years, was 83 years for males and 86 years for females. So our data suggests that the disparity between the age at death for people with learning disabilities aged 4 years and over and the general population of all ages is 23 years for males and 27 years for females. We link the deaths reported to LeDeR with official Office for National Statistics data to receive the verified ICD-10 code for the causes of death. So here we look at the medical conditions that are mentioned anywhere in Part 1 of the Medical Certificate of Cause of Death as reported by the Office for National Statistics. We've excluded those deaths reportedly being due to Down syndrome. The conditions most frequently recorded in Part 1 are pneumonia at 25%, aspiration pneumonia at 16%, sepsis at 7%, dementia, which is a syndrome, not a specific condition, at 6%, ischemic heart disease at 6%, and epilepsy at 5%. Now the reason that we've looked at any causes of death on Part 1 of the Cause of Death certificate is because of concerns about the accuracy of descriptions of the underlying cause of death in this population. First, a large minority of the deaths, 16%, are ascribed to congenital malformations and chromosomal abnormalities, most commonly Down syndrome, and usually in association with Alzheimer's disease. In our view, coding Down syndrome as an underlying cause of death in this way is neither helpful nor accurate. Rather, it should be coded on Part 2 of the MCCD. Secondly, we suspect that there's been some conflating of dementia and Alzheimer's disease in the codes for causes of death, particularly in relation to people with Down syndrome. And thirdly, 15 people with learning disabilities were coded with an underlying cause of death as being due to learning disabilities. Our assumption is that this error is due to a lack of training and knowledge on behalf of certifiers and/or diagnostic overshadowing, where health problems are attributed to a person's learning disabilities rather than to a physical condition. Now let's look at the quality of care provided. A third of reviews completed in 2018 for whom information was provided gave one or more examples of best practice. Some of the comments related to good quality person-centred care that everyone should be able to expect, but there were 3 key areas in which best practice was most frequently mentioned for people with learning disabilities. The first was strong, effective interagency work. Secondly, it was person-centred care, and thirdly was in relation to end-of-life care. Of the deaths that were reviewed in 2018, 89% noted that there had been no concerns about the death. However, 11% of reviews, and that number's 99, noted that some concerns had been raised in relation to the person's death. Now, the concerns have originated from a range of sources, but almost half, at 45%, were from family members, emphasising the importance of the leader reviewer involving the family at an early stage. There was a wide range of concerns mentioned, but they were commonly in relation to delays in diagnosing and treating illness and the quality of health or social care received by the person. At the end of the review, having considered all of the evidence available to them, reviewers are requested to provide an overall assessment of the quality of care provided to the person. Of the 882 adults whose deaths were reviewed in 2018, almost half, at 48%, were thought to have received care that met or exceeded good practice. A further 35% were reported to have received care that fell short in minor areas. 9% were reported to have received care that fell short in significant areas, and 8%, a total of 71 adults with learning disabilities, were reported to have received care that fell so far short of expected good practice that it significantly impacted on their well-being or directly contributed to their cause of death. And the reasons for falling so far short of good practice varied, but they included problems with care that were related to the clinical care of a person, medication and equipment, not summoning medical attention in a timely way, and a lack of coordination of a person's care and treatment. Those whose care fell so far short of expected good practice were also more frequently reported to have had gaps in their service provision that may have contributed to their death. We discussed the key findings from the LeDeR programme with 3 consultation groups, 1 of people with learning disabilities and 2 of professionals and family members. And together we prioritised the concerns and discussed potential recommendations. We made 12 recommendations in all. I'll run through them here. The first 2 recommendations are in response to the availability of data. So the first recommendation is to consider designating national leads within NHS England and local authority social care to continue the active, centralised oversight of the LeDeR programme. The reason for this recommendation is that there's been variation in local delivery and accountability of the programme, and continuing and significant problems with the quality of data and the timeliness with which reviews of deaths take place. We want to address this with national leads within NHS England and local authority social care to continue robust, active, centralised oversight of the LeDeR programme, to maintain the specific LeDeR approach to reviewing deaths, to ensure the quality of completed reviews, the translation of learning into action, and ongoing alignment with the NHS long-term plan. Our second recommendation is for NHS England to support clinical commissioning groups to ensure the timely completion of mortality reviews to the recognised standard. The LeDeR programme is now included in the NHS Operational Planning and Contracting Guidance for 2019-20, with specific responsibilities for clinical commissioning groups. However, some clinical commissioning groups will need support with this, and we recommend that this is provided. The focus of our next two recommendations is being able to identify young people at transition to adult services and people from Black, Asian and minority ethnic communities. Some of the problems with identification of young people at transition centres on the use of different terminology in education, health and social care. Recommendation 3 is that there should be a clear national statement that describes the differences in terminology and references relevant legislation, so that there's a common understanding across each of the sectors and between children and adult services about the population of people with learning disabilities. Recommendation 4 is specifically in relation to the identification of people from Black, Asian and minority ethnic communities. Our findings suggest that adults with learning disabilities from these communities may be underrepresented in notifications of deaths to LeDeR. This is part of a wider issue about having information and knowledge about local communities in order to understand the needs of people with learning disabilities and their families from different backgrounds. So the fourth recommendation is therefore that clinical commissioning groups and LeDeR steering groups should have a clear oversight and be required to report on the population of people from Black, Asian and minority ethnic groups in their area, and to assess whether the number of deaths notified to LeDeR is representative of that area, and use the findings to take appropriate action and inform local planning. Our fifth recommendation is in relation to listening to families. 1 in 10 reviews noted that some concerns had been raised in relation to the person's death, and almost half of the concerns were raised by family members. This indicates the need for families to be routinely invited to be involved in a review of the death of their relative. So our recommendation is for the Department of Health and Social Care and NHS England to support national mortality review programmes, to work with Ask, Listen, Do, and jointly develop and share guidelines that provide a routine opportunity for any family to raise any concerns about their relative's death. Recommendation 6 describes 2 priority programmes of work that we feel are needed. These are to improve the recognition of deteriorating health or early signs of illness in people with learning disabilities, and to minimise the risks of pneumonia and aspiration pneumonia. Recommendation 7 is about service and care coordination. The inadequate coordination of care and appropriate information sharing is a continuing problem in the provision of support for people with learning disabilities. As a response to the last LeDeR annual report, the Department of Health and Social Care committed to commissioning a rapid review of best practice in care coordination or key working for people with learning disabilities by March 2019. We feel that such national guidance is urgently needed. The next 2 recommendations are in relation to the transition from children's to adult services. First, the Special Educational Needs Code of Practice provides the legislative framework for services to work together at transition, and adherence to this is the focus of Recommendation 8. Despite the legislation, we found significant shortfalls in adherence to the legislation which need to be addressed. Contracting agreements should allow commissioners or the commissioning authority to take firm action to ensure compliance. They should take decisive action when breaches of the law and regulation are identified, and should be held to account for the quality of service delivered. Recommendation 9 is about better supporting the transition from children's to adult services. We recommend that the Royal College of Paediatricians and Child Health should be asked to publish case examples of best practice and effective active transition planning for people with learning disabilities as they move from children's to adults' health services. Our final 3 recommendations relate to concerns about potential bias or diagnostic overshadowing. We reported that 15 people with learning disabilities had the underlying cause of death erroneously coded as learning disabilities. That 19 reviews reported that the term learning disabilities or Down syndrome was given as the rationale for a do not attempt cardiopulmonary resuscitation order, and that fewer deaths of people with learning disabilities were reported to a coroner in 2018 than for the general population. In recommendation 10, we recommend that the Department of Health and Social Care, working with a range of agencies and the Royal Colleges, should issue guidance for doctors that learning disabilities should never be an acceptable rationale for a do not attempt cardiopulmonary resuscitation order, or to be described as the underlying or only cause of death on Part 1 of the Medical Certificate of Cause of Death. In recommendation 11, we recommend that medical examiners be asked to raise and discuss with clinicians any instances of bias they or their families identify. And in recommendation 12, we suggest that the Care Quality Commission be asked to identify and review do not attempt cardiopulmonary resuscitation orders and treatment escalation personal plans relating to people with learning disabilities at inspection visits. Any issues identified should be raised with the provider for action and resolution. In May 2019, at the same time as the LeDeR annual report was published, NHS England published a report detailing the actions taken nationally and locally in response to findings from LeDeR reviews and the previous annual report, dated 2016-17. It also contains an action plan for work in 2019-20, with a particular focus on deaths from pneumonia, respiratory disease, constipation, sepsis and the recognition of deterioration in a person, and cancer. And the report is available on the NHS England website. This is the end of the webinar. The next slide shows the contact details for the LeDeR team at the University of Bristol and at NHS England. Thank you.